Here's lesson 35 in our EMT course. This one's on MCIs, multiple casualty incidents. Fairly short lesson with no specific lab assigned to this. It's one of the ops lessons and one of the things that we want you to have some exposure to. Your textbook treats it quite nicely, but we felt like we could add to it a little bit with this. So we're going to talk about the basics of MCI management, talk about triage systems, triage tags, what the transport group does, what the treatment group does, and we're going to move through this fairly swiftly. So what's the definition of an MCI? Well, it depends. I mean, the seat of the pants definition is when there's more patients than we have providers. Some more refined definition could involve when the usual system resources are overwhelmed. Some systems declare it to be X number of patients, like 5 or 6, or when you send a third ambulance. And those definitions may change. Hospitals may even have a different definition than the field system does for what a multi-casualty or mass casualty incident is. And either of those are standard definitions for MCI, mass or multi-casualty. But regardless of any of the definitions, our goal is to save the most lives with available resources, do the most good for the most people. And so these calls are somewhat different in that usually we have plenty of resources to expend on a single patient. And in some cases in MCIs, you have to do things a little differently. A patient, for instance, in a regular, the only patient on a call, a non-MCI event, we have a single patient. If that person's not breathing and has no pulse, usually we would start CPR and work that as a cardiac arrest. Whereas if that is a person in an MCI, most MCI rules and procedures would have us simply open that patient's airway, and if they don't start breathing on their own, then we must move on. Now, the idea being that the likelihood of survival of that patient or others with catastrophic, almost certain to be fatal injuries, we should not expend resources on a lost cause. And that sounds terrible. It's extremely hard to do in real life, but that is the goal of a mass casualty and a triage sort of process. Triage simply means sorting patients, so you identify their acuity quickly and sort them and classify them. Sometimes that's as simple as red, yellow, green. Sometimes it gets more in depth. Red, yellow, green tends to be a very common one. Red, yellow, green, and black or gray or something. Where red would identify your highest acuity, sickest, life-threatening right now, needs intervention. Yellow would be have the potential to have a life-threatening problem, but they're doing okay for now. Green would be those that really don't have any potential for a life threat. They may be in pain, they may have an injury, but it's not going to cause them to die. And then the gray or black or whatever other color is identified is typically for those that either are deceased or expected to, regardless of what we do. So there is usually someone assigned to treatment, one assigned to triage, and one assigned to transport. The treatment group leader in the treatment area, the treatment function, is based on-scene treatment. Now, in a normal call, we do some treatment on the scene, and we start transporting our patient. But in an MCI, there may not be enough transport vehicles available, and so extended treatment on scene ends up being the problem. And then transport, that function is responsible for appropriately distributing patients to destination hospitals so that we don't end up with all the patients at one hospital and 3 more hospitals standing around with no patients coming to them. As far as triage schemes go, START triage is a long-standing standard. There are others out there now, SALT and some others. START is what we use in our local system, and START's the most common one. It stands for simple triage and rapid treatment. So the challenge here is to deploy a scheme that is enough like everyday ops that you can actually use it, but it has to be able to accomplish this sorting of patients, which we don't do on a regular basis. When you have this rare event and it is overwhelming in size and scope in many cases, to try to use processes and procedures that you never use except once in a blue moon when you have this MCI, that just doesn't work as well. So the more that we can get MCI processes to mirror or look like or feel like just an expanded and slightly adjusted version of everyday stuff, then the better off we'll be. Triage tags are used to label the patients once you've sorted them, and there are numerous different types. Some have 3 or 4 labels. Typically, you're going to be able to tear off labels that you don't need, so the last one showing is what you're using. In this example of the picture, this patient would be triaged red or immediate. That's the last one showing on there. The yellow has been torn off. In many triage tags, they give you a reference guide right there on the tag, and that would be what we would think is a best practice. Rather than trying to remember rules, if you can read, then there's your rules. And so each patient would get a tag. In some systems, they will use colored tape of the same colors. That may be quicker and easier to apply. You just kind of marking tape sort of stuff, and you just wrap a piece around, tie it, and go from there. Usually these are placed on the wrist or on the leg of a patient. And I mean, again, we could spend an hour and a half talking about different triage tags and how to use them. This is part of your orientation when you go to work somewhere. The treatment function, again, we said there would be extended treatment with MCIs, and that's usually at a casualty collection point or treatment area. And so because this MCI is an unusual event, we have unusually long waits for transport. There aren't enough vehicles to transport patients, and typically the sicker ones go first, and the idea is that we would be able to get them moving toward definitive care. And when you think about it, for the most part, an MCI is usually a trauma event. And where is trauma definitively cared for? Oh, at a trauma center or at least a hospital. So really, trauma care needs to occur at the hospital, so transport is a big deal with trauma care. And with MCIs, if you don't have enough transport options, then you have some delayed treatment in the field, and that makes triage an extremely important task. The other thing about treatment on MCIs is that your patients get worse because you're in front of them for a very, very long time. If you think about the urban environment where you have a 4 or 5 minute transport time, your patient's condition typically doesn't change very much in 4 or 5 minutes. But if you're looking at a 45-minute wait for transport, and then your transport time, well, now you have a much larger window of time, and it's much more likely that your patients will get worse in front of you, and they may need to be re-triaged. A patient that was triaged as yellow, which is delayed, can wait, isn't going to die right now, may get worse and become a red, and that's why certain triage tags are ordered in the way that they are. And who does this at the treatment? Well, this is where your highest skilled folks should be doing that. You don't need a doctor doing triage, you need a doctor doing treatment. If you have plenty of medics, nurses, docs, and people to staff your treatment area, then it's fine for those advanced folks to do triage as well. But a triage system should be able to be implemented by someone at the EMR or EMT level. It doesn't require a great deal of clinical knowledge or experience or clinical judgment. It is what it is. You apply the rules and get them sorted and move them to a treatment area, and then they can be re-triaged and resorted once they're in that area. The treatment area is where you're going to really have a bunch of supplies. It was fashionable in our system about 20 years ago to use the first-in ambulance as the treatment area, and we would use supplies off of that truck and take supplies off of that truck, and we, in essence, buried that truck at the scene. It wasn't available for transport, and that may not be the best plan, may not have been the best plan, but you're going to need some supplies, and you may need to ration supplies until we get a legitimate resupply chain kicking in. In many systems, ours included, there are trailers that can be brought to the scene of an MCI that have amazing amounts of equipment but it takes a while to get those there. They're not in the initial dispatch, and so there's going to be a time delay until your resupply kicks in, and you may need to realize that if you're sending an ambulance out with a patient, you're also sending a bunch of supplies out with that patient that you really may not need, and so that's the case. So where do you put treatment? Well, it needs to be in a safe spot, because once you set this up, you don't want to move it. You want to set it up very much like you would a command center. And you don't want to be moving this place, or a base of operations. It needs to be safe. It may be not exactly right next to where you were triaging, but it ought to be pretty close to where you're going to transport. But there's numerous variations. So if your task was setting up treatment, just be thinking about that, and that you need to be away from the action, but not extremely far away from where you're going to transport. The transport's role, the transport section or unit, is about moving patients to hospitals. And the idea will be that where you normally might take just one patient per ambulance, you need to take as many patients as you can per ambulance, or whatever other transport vehicle that you have. We've used school buses in the past to move a large number of patients that were all very minor injuries, and we were able to transport them in one vehicle to the hospital where they were re-triaged. You may have to alter your destination preference. The patient may not get to pick where they go when the big MCI is going on, but that needs to be figured out ahead of time. There are rules in place in many systems that say that you must not pull into a hospital and drop off one of your patients and then leave that hospital and take another patient to another hospital. That once they arrive in the parking lot, they've arrived at that hospital, and they must be cleared based on federal EMTALA laws and such. It may be there's a disaster exception for that. This all needs to be figured out ahead of time. Emergency planners have lots of things to plan, and these are some of the things that they need to plan. These are the things that would be alterations to our daily ops that are different for our extreme bad day MCI ops. Carefully consider who can drive ambulances. Again, everybody wants to help, and you can create additional chaos unnecessarily. Plus, you're putting people in a role that they're not used to and not trained for, and so this can be the same on any day. I mean, who can drive your ambulance with just a single patient is an issue in terms of their safety and their training, and the safety of the other people in the ambulance. And on MCI day, everybody wants to help, and so this needs to be worked out ahead of time. And then there's this concept of mutual aid, where you get assistance from other systems near you. In our local system, we would get mutual aid from each county around us, including the large Jeff City to our south, 15 minutes to our south. We might be able to get 2 or 3 ambulances from there. So what do you do with them? Well, they're really best being assigned to that MCI because other calls continue to go on. And very few systems are staffed with extra paramedic ambulance units just sitting around. Those units are usually pretty well utilized, and they're utilized to cover the normal call volume. And so if you have an MCI, particularly it's a weather-related MCI or a terrorist or something related MCI, there's going to be lots of calls, more calls than normal, and then you have this one where there's a whole bunch of patients. So when you do get some help, it seems more appropriate and efficient to assign that outside help to one scene rather than try to spread them out and have them find their way around your city and run your regular calls. Distribute your patients according to whatever the local capacities are. This takes a lot of communication, and the transport unit leader probably needs help. Probably needs 2 or 3 people to do that in order to keep up the communication with the hospitals. Again, this is the sort of stuff that should be planned ahead of time and exercised and drilled because this is abnormal. This is not usual ops, where maybe a triage system is not that different, and transport issues, in terms of, or treatment issues on the scene are not that different, but distribution of patients may be, and tracking those patients may be. What we do not want to do is just transport the MCI and drop it in the ER. Now, if you only have one hospital in your system, then you may not be able to avoid that. But the idea that all the patients would go to one hospital in a system that's got 3 or 4 hospitals is really silly, and you should avoid just relocating your disaster. The same as relocating your hazmat patient. You should decon your patient in the field, not transport them to the hospital, and then we end up having to decon the hospital. So, and the other thing is that patients will self-transport to the ER. So maybe you're on a scene of an MCI and you're counting 22 patients, but there may have been 32 people involved in the event. 10 of them said they're not going to wait around for an ambulance. This looks like a mess, and they self-transport. And so ERs may be overwhelmed by walk-ins. And that's where your transport person is on the phone, on the radio, in some way in constant comm with that hospital. How you doing now? What's your status now? How many can you take? And the transport role is to divvy those patients up appropriately. And again, you're going to need more than one person and probably a quiet place. This is the advantage of a command vehicle or a staff vehicle of some kind, where you've got radios and phones and you can be out of the middle of the event, in constant communication and sorting these things out. So MCIs are a big deal, and they're hard to manage, and there's different tactics that we use. Again, inbound patient reports may not be all that helpful. If you just have one patient, it's a normal day, the ER would like to know what you're bringing, but they may be suspended temporarily during an MCI because who can keep it straight anyway? And so the ERs may simply say, just show up and we'll deal with you when you get here. Typically, you drop your patient off on a regular day at the hospital, and in most systems, your patient is received by the ER in a short period of time, and you're able to clean up your truck and get back on the road. But if that ER is absolutely overwhelmed and overcrowded, then the turnaround time at the hospital may be extended. And so that may be another alteration in daily ops that needs to be looked at in terms of pre-planning. Consider using those first vehicles that transport the ER to become resupply. So perhaps you can get a bunch of supplies that you might need at the scene from the ER, or you can get those dropped off at the ER, or ideally perhaps multiple MCI vehicles, MCI equipment caches would be at the ERs where they can be picked up by the first-in units and transported back to the scene. All kinds of things can be thought about. So planning for these events is a big deal and requires some detailed thought and some innovative thinking, and that's where emergency management, emergency planners come into play. So whatever system you're working in, if you're interested in that sort of stuff, get involved, because lots of smart people come up with good ideas usually. Anyway, the destination ER may also be a good place to add supplemental staff. So in a lot of places, if they're staffing 2 units, 2 ambulances around the clock, during an MCI, they might be able to get additional staff back in to staff some reserve vehicles. And that might be a good place to add some extra staff to your ambulance as well. Just depends on the nature of the event. And realize that if you're accustomed to being able to take fire department with you on a usual day with a very sick patient, either to drive or to help in the back of the truck or both, they may not be available on some events. An MCI that has a fire rescue component to it may mean that the fire department doesn't have anybody they can spare to drive your truck or go with you. So all these things need to be thought about with MCIs. So, summary thoughts, trying to wrap this up. MCIs are rare. They come up all of a sudden. They're unusual. They must be planned for. But if nobody trains on the plan, or the plan is completely different than everyday ops, the plan's not going to work. People are going to revert back to what they normally do. Because when things go bad, the kind of folks that work in EMS just fix it. And they're going to fix it with what they think makes the most sense. So if you're going to go to the trouble to make a plan, you got to train on the plan. And if you're going to make a plan, It shouldn't be completely opposite of what they do every day. Ideally, it would expand on what they do every day and then make necessary adjustments, and everybody would be aware of those and able to quickly access what are we going to do different. The MCI plan has been implemented. Here are the top 5 things to do that are different than every day. That needs to be easily accessible, not buried in a 30-page emergency management pre-plan. You know that when the MCI is over and we do a rehash of it, you absolutely know communication is going to be on the list of things that needed to be improved. It's going to be difficult. Just remember that because you have a radio does not mean you must talk on it a lot. Listen a lot, talk when you must. Think about the importance of your message relative to the receiver and everyone else. It may be important to you, but make sure that it really matters before you take up some airtime. Say what you got to say, get off the radio. Face-to-face works great on a scene. The radio is for when you can't be face-to-face. Then the last thing is freelancing is a bad idea. Solve your own problem is a good idea. So if you can be self-managed, self-reliant, not needing a bunch of help, not needing someone to hold your hand, not ask a bunch of questions, that's awesome. But don't just start fixing stuff without paying attention to what you're doing. I said that EMS people like to just fix things. That's our nature. Particularly paramedics can work alone, and they're going to figure out a way to solve a problem. And so that's a good thing, but try to work within the system and certainly make sure that you are dispatched to this event. You're supposed to go to this event rather than just showing up from home and going to the big one and trying to jump in there. So work within the system, work within the plan, know the plan, and let's hope that the plan's been made by planners that are thinking about how the plan might actually work and go from there. So that's our little 2 cents worth on MCIs.